Welcome to this episode of Season 6 of The Common Bridge, where policy and current events are discussed in a fiercely nonpartisan manner. The host, Richard Helppie, is a philanthropist, entrepreneur, and political analyst who has reached over 5 million listeners, viewers, and readers around the world. With our surging growth in audience and subscriptions, The Common Bridge continues to expand its reach. The show is available on the Substack website and the Substack app. Simply search for The Common Bridge. You can also find us on YouTube and wherever you get your podcasts. The Common Bridge draws guests and audiences from around the political spectrum, and we invite you to become a free or paid subscriber on your favorite medium.
Hello, welcome to The Common Bridge. I'm your host, Rich Helppie. We're back heavy on policy, and the biggest part of the economy continues to be the healthcare economy. We've talked about some of the economics, who the players are, and when it comes down to it, it's the physicians who take care of us. Those that diagnose us, treat us, look for the best way to make us better, and more importantly, to prevent us from becoming ill. And today we have with us Dr. David Harlan. He is the William and Doris Krupp Professor of Medicine at the University of Massachusetts Chan Medical School and co-director of the UMass Diabetes Center of Excellence. He also directs the Breakthrough New England Center of Excellence, and his research focuses on the mechanisms underlying type 1 diabetes and developing new disease treatments. He's also been a little frustrated by the healthcare delivery system, so he co-founded a company called Stability Health. You can look them up, Stability Health LLC, focusing on providing diabetes expertise to patients and their physicians with one goal, one we should all have, improving outcomes in a cost-effective way. We're joined also today by Dr. Barry Meisenberg. He's the chair of medicine and the executive medical director of cancer medicine at Luminous Health. That's a health system based in Annapolis, Maryland. He led the health system's clinical and research response to the COVID-19 medical crisis, and we'll be talking about COVID today. He's a visiting professor of oncology at Johns Hopkins University and the Kimmel Cancer Center, and he has led efforts to organize cancer services internationally. And in addition to his clinical and scholarly activities, Dr. Meisenberg organizes a medical humanities event for medical staff and trainees called the Diastole Hour, which uses medical humanities content to help physicians regain the meaning in medicine. And so much is talked about with economics that we need to get back to what it's all about. Also with us is Admiral Matt Nathan. Dr. Nathan is a retired Vice Admiral and previously the 37th Surgeon General of the United States Navy. He also was a previous Senior Vice President at Wake Med Health System in North Carolina. He's currently a Senior Editor for Harvard University Social Impact Review and a previous Senior Fellow in the Harvard Advanced Leadership Initiative. He's held several faculty and academic positions throughout his career, and he says that one of his hobbies is fact-checking Dr. Harlan and Dr. Meisenberg. So listeners, readers, and viewers of The Common Bridge, strap in. We're going to talk about all things relative to healthcare and medical treatment. Doctors, it's an honor to have you with us today. Thank you for joining us.
My pleasure.
So, I hope that we're going to have some advice for the people that are listening or reading or watching this episode. They're ultimately going to become patients and or caregivers so that they can all understand healthcare. And if you were in a single question interview and said, what message would you like to deliver to our audience today? What's that thing you're going to tell them? And Dr. Nathan, why don't we start with you, if you don't mind? What is it that you really want people to understand?
Well, thanks for the question, Rich. I mean, it's a wide landscape of good and bad right now in healthcare, and my colleagues know that I look at the evolution of healthcare, at least in this country, over the years, and am fascinated, encouraged, and disappointed by some of the changes. I think people need to understand that the role of the healthcare giver, and let's say the physician and the advanced practice uh, provider, the nurses, the role has changed somewhat in that autonomy has been ceded from the profession to business. And those business practices have created some very good business practices which allow mission sustainment, but have also created a gulf and a disparity between the patient feeling a kinship and a personal relationship to their healthcare provider. And so I think a lot of people feel adrift right now because they don't feel they have a community connection or a personal connection with their providers or the ability to access them. And I think that's something that we have to look at very hard in this country to try to repair or try to reorganize.
Great. And I think a lot of people can very much relate to that. Dr. Harlan, when you think about reaching our audience today, what is maybe the single most important thing you want people to understand today?
I would say that over the last several decades, let's say 4 or 5 decades, the role of the healthcare systems has shifted from one where we responded to episodes of care, an appendicitis, a broken femur, to chronic disease management. Now the preponderance of the cost of the American healthcare system is for diseases like diabetes, even some cancers like chronic myelogenous leukemia, obesity, thyroid disease. And our current system is not equipped to support that chronic disease management. And we have to, as my friend Admiral Nathan has said, I think we need to find ways to steer the healthcare system back toward that chronic disease management, toward health, not episodes of care, but promoting health.
Yeah, that's, I think, very, very important. A lot of our audience members are going to be able to relate to that. And Dr. Meisenberg.
Yeah, I would like to add to Dr. Harlan's comment that there's a term for that called salutogenesis, the creation of health, the opposite of pathogenesis, the creation of disease. I would say that, as I think Dr. Nathan implied, we don't have a single system. We have a conglomeration of multiple experiences because no one designed this health system that we have. And although you're asking on behalf of the listening public who will experience it as patients, I will tell you that from a physician's side, we're very concerned about the way this is going and the influence of business, private equity, profits in driving medical decision-making. And among physicians who mostly go into the field for the right reason, and the public should be reassured about that, there's a form of moral injury because the system doesn't allow us to practice in the human-centric way that we would have liked and that we still talk about in lofty terms. So, yes, there has been a shift, and the fact that most physicians are now employed by entities, some not-for-profit, some for-profit, is contributed to one of the many trends that I guess we'll unpack shortly.
Well, I sense a great deal of frustration with all three of you with the ecosystem around healthcare, and of course, many patients, caregivers, families feel that. And as you were each speaking, I've said, yeah, that's right. There's another party in the room. It's not my physician and me. It's my physician and, gosh, we both have to go ask that payer and what rules that they might have. So in the United States, when we look at healthcare and medical care, what are we getting right? And what are some areas that we're getting wrong and we need to improve? And I'll just throw it out to whomever would like to go first.
Well, I would I'm very glad you start with this, because we don't want to lose track of that. And that what we have right, I think, is advances in the field, dramatic in oncology, and probably other areas as well. We've got dramatic improvements in technology, if you can access it. We have a cadre of very well-trained physicians, the envy of the world, the way American physicians are trained. And I would say, by and large, the same is true within our hospitals. So I know when I'm talking, it sounds like there's going to be a but let me just end it with a period and say those are some of our assets, which I think are very, very strong, and we should take pride in them.
Great. Matt, Dave, anything you'd like to add or fact check on that? Just kidding about the fact check, but if it's...
I'm expecting.
No, I agree with Barry. I think that we've come a long way in patient safety. We have a standardization now in many places. I'm from the Navy, right? That was where my career was centered. And so the standardization there in the Navy nuclear reactor program and the standardization of how you land and take a jet off an aircraft carrier, that standardization, that template across the operational theater of all those things results in almost a zero serious mistake or mishap. We haven't quite got there yet in our operating rooms and our clinics and our sedation systems, but it's coming. And so I think that's been a huge improvement, where you can be treated the same way in the same hospital in one coast or another. To Barry's point, education now, we can, there's a lot more advances in the technology and how we can train and teach future nurses and doctors and allied health. And I think that's wonderful. And we cannot remove the two-edged sword from the room, which is the advances in technology. So AI and imaging and the new ways of diagnosing patients have really been an amazing advance in helping diagnose and stamp out disease. On the same hand, it's removed some of the humanity of the provider spending time with the patient and getting to know the patient. And so you have to balance the good and the bad of all that.
That's it must be quite a challenge. Dr. Harlan, anything about what are we getting right? What are we getting wrong? What are we getting right? What are we getting wrong?
I'll start with a couple comments that my colleagues have made. First, Rich, one is both Matt and Barry have been friends for over 4 decades, so we've known each other for a long time. And Matt, in his fact-checking exercise, is kind of like the Maytag repairman. If you know, he's still waiting for some fact that he can correct. And then I want to define for you something that Barry said, which we all use, and I don't know if it means anything to you, about moral injury. Do you understand that term, Rich?
I'd like to hear your definition for sure.
Well, what has happened is in the business world, physicians are very unhappy with their practice, and the leaders of the healthcare systems will say, well, they're burning out. What can we do to prevent burnout? Can we give cookies? Can we have a doctor's lounge? And what they fail to understand, and what physicians have defined, is it's not burnout. We are feeling it's a moral injury, that we went in to this profession with a profound mission that is being taken out from under us. So we all agreed, Barry, Matt, and I agreed, that we don't want this to be just a complaining session. There are some great strengths to the healthcare system as it's evolved. And I'll just add a little bit that the biotech industry in this country, Genentech, Biotech, Amgen, those are, and now Vertex, and they are driving curative therapies that were undreamed of when we were in medical school. It's truly miraculous to see these things coming down the pike. What we're getting wrong is what you said. The fundamental principles of medicine are the sacrosanct relationship between a patient and a provider. And exactly what you said, Rich. When I sit in a room, I say, right now it's just you and me in this room, but it's actually a quite crowded room. And those people that aren't here, the silent partners, say they care about your health, but their actions belie that. They don't. It's a profit thing for them. And that's damaging the relationship. It's creating the moral injury that Barry alluded to.
Yeah, that we've always talked about. It's quality, access, and cost is the most difficult, but we seem to default to cost more than anything else. So you've all been in practice a long time. You've seen a great number of changes. I know one of the most profound changes, my guess would be you gentlemen were 70 to 80 hour a week people for a long time. The physicians entering practice today, they're 45 hour a week. So we're not going to have as many doctors, and we're going to have to rely on AI and allied medical professionals and telemedicine. And we don't have a financing system. We have a hodgepodge of financing methods, none of them that work particularly well. I just wonder, have you looked around internationally, and is there a better method for healthcare services in terms of access and choice and diagnostics and treatment and cost? And, would it differ if you said, well, somebody's really getting it better on cost and someone else is getting it better on access? What do you think are other countries doing?
Yeah, I think that's a complicated question, maybe even more complicated than you realize, because it's because other countries, 120, 160 countries, and they could all do it a little differently. Yeah, one thing that differs is in societal expectations of care and access. And we come from a background of individualism and expectations of everything's reachable for me and everything's accessible to me, and I don't care about the cost. And other societies have, over time, and I'm thinking mostly about the UK system, have sort of got a societal agreement that some things are going to be too expensive to afford. And they're at that decision even before you get the disease that warrants some greater expenditure. You mentioned early about changes in physicians' willingness to work many, many hours, long hours. And yes, it's a trend we've noticing in our training of doctors has become, and then when we birth them and when the fledglings leave the nest, they go out into the world, I think this generation, with some exceptions, I don't want to make it too stereotyped, but or place limits on what they're willing to commit, and they seek shift jobs that are amenable to shift. I have my own term for it, which I don't mean to be insulting, but recognize the phenomenon. It's called partialism. And it means that I turn my pager off, or I turn my phone off, and I do my shift, or I commit to my practice. Now, many physicians don't practice that way, and we've all benefited from their free time that they give, but I think that is shrinking. And it's interesting that it's led to this idea of concierge medicine, this phenomenon. And I know Dr. Nathan has some, feelings about what concierge medicine really represents. So, Matt, I'm handing it off to you.
Well, I think access is a failure point in this country, and you can look at the anchor studies and see that 2 zip codes next to each other in the Chicago area have a lifespan difference of 10 years. And it boils down to access and preventative health and being able to manage chronic diseases. And so I look at concierge medicine as a patch by people as a symptom of a failing access, healthcare access in this country. And physicians are overwhelmed. They feel that they are having to load more and more trucks with less and less appreciation. The training that we've given them now, which was born out of too much arduous hours and longevity, which would grind you down and lessen your ability to be attentive and on your toes. So that was a good thing. But we have, I think, overshot in that we have created a system where physicians no longer feel that they are really in a profession as much as they feel they're in a trade. Some would argue.
That's an important distinction, a trade versus a profession. And when you think about the advent of hospitalists, so if a patient is admitted, the day-to-day care is done by a physician assigned to the hospital. We're all familiar with the surgeon on call for the ER. You want that specialist, but you might get the more general practitioner. But look, proponents of concierge medicine, which is where you have a doctor, you pay them a flat fee, and that's your first point of contact for preventive, for diagnostic, and for treatment. They'll say, look, that's a throwback to the role of the primary care doctor, the family doctor. But you don't seem to like the notion of concierge medicine.
Well, I don't like I know people who practice concierge medicine are very, very good, and they use their time that they can save to do pro bono work for the underserved. And so I think those are wonderful examples of people who have tried to compartmentalize their practice and leave time to do other things. So I don't necessarily vilify the physicians involved as much as the system, which has created the need to pay for access. When you have a country where you have to pay to be able to get a hold of a physician or a provider to take care of you in a retainer fee, you've got a problem. And I'll finish this one, my one soundbite here with one thing. There's some debate on the legitimacy or the veracity of the story of 15th century China. But there's some historical references where in those days, people paid their physicians while they were well or uninjured. And they stopped paying when they got sick or when they injured themselves. So, what a great motivator for a healthcare system to keep you robust and alive. In those days, if two Chinese physicians saw a patient about to get run over by an ox cart, they risked their own lives to push him out of the way to keep them from getting injured. Today, if that happened, and I'm being a little flippant here, they'd say, well, this is going to be a bad accident. I feel sorry for that guy. We're here to take care of them. So this gets back to Dave's and Barry's point that we have become centered around remuneration and reward for the care that's provided, not the health that is maintained.
Well, if I could be flippant back right at you, it's the model we've got now is the so-called employer-based insurance. If someone's injured or sick, they quit getting covered also. So it's, maybe in 1,500 years, we haven't moved that far. So when you think about like the timeline of healthcare, we got prenatal to end of life. And I think there's been advances on all of that, and particularly end of life, that there's not the keep people alive at any cost. There's a point in time where it's palliative care, hospice services, etc. But in your, hands-on work, what do you say? What do you think if you said, "Hey, the best served people in the United States of America in that spectrum from prenatal until end of life, who are the best served, and who are we really leaving out?"
Well, those who are best served are those with resources, Rich. And that's always the case. And one thing I've learned from history, I'm a student of history, is that no one wants to be told what to do or what they can or cannot do. It's best if we have a system that aligns incentives and I think affords what Adam Smith called the invisible hand. Let individual incentives drive what is delivered. Now, of course, we have to find a way to support those who have the least resources in our country. And that's you ask about concierge medicine. I sort of like the concept of it, except that it leaves out very significant proportions of our population that even on a discounted basis can't afford health care. So we have to figure out a way to support those people as well. I tell people that I have TB, and by that I mean true believer disease. I believe in the Hippocratic Oath and that we should provide health for everyone. And the last thing I'll say about this is you asked earlier what system is best in the world for healthcare delivery. And I think worldwide people are having a difficult time shifting from the episode of care to the promoting health and preventing chronic disease. No one has figured that out. But I think that the U.S. should lead that charge. And you can do it one of two ways. You can wait for the system to collapse. And I worry that that's happening. Providers just don't want to be a part of this anymore. Or then build anew, and that would be horrible, but it happens periodically. Or someone has to build a better system where people are voting with their feet and going to that better system, and then the hearts and minds of everybody else will follow when the dollars go to that new system. But it's yet to be devised. No one's figured it out.
Yeah, I think, as I said earlier, we don't have a system that anyone created. We have a system that evolved. Business interests are driving it now, and whether that's actual, pharma industry, hospital industry, or just private equity investment in physician practices, and patients are not well served. And the reaction to this healthcare CEO's assassination is evident of the level of dissatisfaction, and maybe the one silver lining that could come out of this horrible event is that people who participate throughout the system recognize the need that we really need to change aggressively what's been going on. And like David, maybe I'm naive, but I believe we can make some rather rapid reforms if we have the will.
Well, it would be surprising if our pathway to healthcare reform was people being murdered on the streets of Manhattan, which I can't think of anything worse as an impetus for change. But perhaps we can educate folks. And you made mention of history. So here's a couple things in history. People used to save money and pay their doctors, or they would pay their doctors with farm goods. I had a great uncle who was a physician of some renown. He started in a small Minnesota town. He was literally paid in chickens. And apparently they were good chickens because he went on to practice at Walter Reed, actually. And then we had, the notion of hospitalization. You're going to have hospitalization services, insurance, because if you were sick enough, you were going to go into the hospital. Oh, well, things are going to get done outside the hospital. So now we're going to start covering primary care through insurance, which is really preventive care. And you're going to consume that anyway. So it's not really an insurable event by the definition of insurance, but we started washing money through lots of hands. And at the same time, if you go back to the old adage about an apple a day keeps the doctor away, now we have an obesity crisis, and the pharmacists are saying, look, we'll give you another drug to treat your obesity. And I think our potentially incoming Secretary of Health and Human Services said, for the cost of Ozempic, we can give everybody organic food and gym memberships and deal with obesity that way. So when I think about the things that we're getting wrong, how often in your practices do you tell somebody, get off the medications and start jogging, get off the medications and start eating better? Like how big of a part of your world has that been?
Well, David, that's with you, right? That's your whole practice.
That's front and center.
Much of it, anyhow.
Yeah.
Matt, you want to say something? I have comments.
Well, I think that's front and center for you, Dave. But Rich, you bring up a great point, which is, we tend to quickly try to admonish the healthcare provision systems when you've just brought up a huge point, which is the reason a lot of people have failing health is because of behavioral health habits which contribute to it. And one of the differences in other nations where they have better mortality, because right, the soundbite that everybody loves to talk about is the fact that we spend more per capita on healthcare in the United States than any other country in the world. And yet we don't rank anywhere near the top in wellness and health indicators. Our cholesterols are higher, our weight is higher, our obesity factors are higher. And so our fitness is poor. And so in Scandinavia, they have better health, but they also eat better and they have a more fish-based diet and they walk everywhere. And Dave's practice is, I'd love to hear his thoughts on this because he's the one who has to deal with when patients get on the talking scale, it says one at a time, please. And so he's trying to figure out how to, get people back into a reasonable habitus where they have a fighting chance with their diabetes.
So Dave, I would like to hear about this because if we can keep people off that pharmaceutical chain, they have a chance. And gentlemen, I think we should come back to the social determinants of health. We know what they are. And when I see about the spend on healthcare versus the mortality statistics and being a data guy, it's like, yeah, I can take those apart. They're really not cause and effect. All right. And what I would tell people, if you're sick or injured, you want to be in the United States of America. And that's provable over and over again. People have this idea, well, Canada, you got everything. Well, you don't. I live on the Canadian border and I hear the public services announcements. And they, like every other single payer plan, they control the budget by limiting access. And that's why every hospital in the Sun Belt and on the border have arms wide open for Canadians with resources who can pay. But before we go down that tangent, that rabbit hole, Dave, how about it? How do we keep people well in the first place? And how much of the system for finances are you working against trying to get there?
Well, I have several comments, and I'm going to quote people, which I always do. First quote I'll say is Reagan's, who said the closest thing to perpetual life is a government program. And I would rank right up there prescriptions. My brother's a neurologist, and he knows the people that took care of Barney Clark, if you remember Barney Clark, who got an artificial heart. And he seized after he got it, and the neurologist went to see him, and he was on he was dig toxic, Barry and Matt. He was on a drug for making the heart squeeze better when he had a mechanical heart. Nobody had stopped it. I mean, that kind of stuff happens all the time. You alluded to the new Health and Human Services guy, Rich. And his uncle was a famous man as well, who famously said, ask not what your country can do for you, but what you can do for your country. The least utilized resource for healthcare in this country are the people. And JFK also established the presidential fitness program. We just need to get back to that. We need to have the American public
take the stairs.
Taking care of themselves, not smoking, not drinking to excess, getting out and walking. And those things can influence lives, as we know from smoking and drunk driving. It can matter, and it does. And those are the most important things.
So I would say that, I'm sorry, Dave, go ahead.
One last thing, and Barry, I'm sorry, that is what we're all facing is what is commonly called the tragedy of the commons as well. There's a limited amount of resources and everybody wants the Cadillac, and that's just not sustainable. So we just have to somehow return some ownership to each of us for our own health. We have to. I do that. I get people all the time. I talk to them about their diet and their exercise, and very frequently we can get them off expensive medicines. And here's the kicker. They feel better. At the end of it, I say, do you want to go back? Oh, no. No one's ever helped me get back to feeling this way again. It is the right thing to do, but it takes time and commitment.
Well, there's never been a medication invented that does one thing. It's always going to affect you in multiple ways. So if it's treating that underlying disease, it's going to maybe make you uncomfortable someplace else. In a prior episode of The Common Bridge, we had Dr. Ken Cooper, who of the famous Cooper Clinic, coined the term aerobics. And I asked him, his last message, and he said, "Walk your dog, even if you don't have a dog." I thought it was a great close. So getting in motion is very, very important. But if you think about what we've tried to do legislatively, and this is a program about policy, when we started looking at healthcare reform some 35 years ago, Clinton administration, the famous book written by Tom Daschle, then Speaker of the House. And he said the problem with Americans is that they want every treatment that might make them better. And I thought, well, that was an interesting take on it. And then I looked at the Clinton Care Bill, which I read as part of my work. And they said, you know what? We don't think people can make good decisions. So we're going to use the law enforcement system to let people, keep people in line so that they don't do diagnostics and treatment. So by way of example, low birth weight babies, it's going to be illegal to treat them below a certain level. And today, babies can live at 22 weeks gestation. So I think my view is that we were doing much better on the prenatal side. We're doing a little better on the end of life with not trying to do so heroic. But in the middle are people living healthier lives. And what should we be doing as a healthcare system? So let me tee that up. Gentlemen, if you could make one change to the healthcare methods in the United States, what would it be? Just imagine it is, a magic genie or someone that says you get one wish. What would it be?
I would start by saying payment reform to pay for the services that you have just mentioned and that Dr. Harlan knows he desperately needs for people with prediabetes and diabetes. Because as someone said, there's the ox cart is how we pay for care. We pay for care for advanced disease, and it's disproportionately weighted to intensive procedures, which, by the way, is not a new finding. And there's a wonderful pamphlet called The Doctor's Dilemma, I think from the 1890s by George Bernard Shaw. And in his preface, he says it's a crazy system which pays you, £1 for amputating your foot, pays £2 for amputating at the knee, and £3 for amputating at the hip. And who gets to decide? The physician doing the cutting. He said that's a crazy system, and it stole the system we have. And I can tell you, as a leader in my health system, we struggle to pay for mental health care, for preventive care. There's no money in it, and it's therefore easily ignored. Sorry to be passionate, but I am.
Yeah, this is what our audience needs to hear. That passion.
I echo your sentiment, Barry. Rich, all of us, we've known each other for 40 years, and we all met each other in the service. So all of us were practicing Navy physicians, and then Dave and Barry went out and did amazing things in the private sector, and I forgot to get out, so they just kept promoting me. But I've led in the private sector and not-for-profit healthcare system, and what I'm about to say is going to create screams through the hallways of some of the fine physicians that I worked with in that system, who are fine physicians. You have to do away with the fee-for-service system. It creates a hunger or a thirst for doing more and more care, not because of malevolence or necessarily greed, but it's just human nature to work yourself harder and to try to do more with less. And yet the other side of the coin, which is the more of the socialistic side in the service, where everybody's salaried and the surgeon is making about as much as the non-surgeon. isn't a panacea either, right? You alluded to Canadian system. I was in England for several years, participating and watching the NHS. That system is on the rocks right now as well, because it's incentivizing people when they're just salaried, and if you don't meter their workload and they're salaried and you're working too hard, people get despondent and burn out and demoralized. So there has to be a balance, but we have to be able to figure out how to feel comfortable in a system where salaried providers who have quality of life can give good care, feel unfettered by too much regulation, and that's going to be very hard to get there. You're going to have to basically unplug the computer and reboot all this and plug it back in again to get this done, and it won't be without tremendous gnashing of teeth to get there.
Right.
I guess my pithy comment, Rich, would be to have somebody come in and look at everything where a healthcare dollar is spent and ask the question, how does this promote the health of our populace? And there's layers upon layers of administration and monies handed back and forth under the table that are not viewable by the public, that have zero impact on health, zero.
And one source of that is the fact that we have so many different insurers. Physician offices and hospitals have a large staff just to communicate with all these different payers.
That's right.
And although there is technology used, it hasn't actually simplified much. And, the word denial has been in the news recently, but there actually allows insurers, and I don't want to make it sound like insurers are the only force driving up cost and reducing delivery, but it makes it easy for them to do denials because their systems are so complex for approval. And the delay, even if they ultimately pay later, the longer they keep the money out of the hands of the providers, the more profit they can make on their investments. I'm just cynical enough to believe it's a strategy.
I can tell you with absolute clarity, their computer systems are built to do just that.
Yeah.
To deny claims.
Yeah.
And to downcode the claims while the providers are trying to.
So the question: why is it so complex? Why is that the default position? And why do hospitals have to hire so many people to take care of this transaction? With a single payer, perhaps it would not be so complicated. Perhaps.
Let me throw my one change I would make if I could make one change. I would take away the tax preference for employer-sponsored benefits. It was put in place in the 1940s to get around wage and price controls.
Right.
And I think if you started showing up on people's W-2 the cost of that health plan, there would be a revolution, and the insurance markets would then be reset toward the care for the things nobody wants, the cancers, the broken legs, car accidents, etc. And people would be coming into your offices saying, how do I stay well? Because it's too expensive to get sick. So that would break the back of this money changing hands. It would take out that administrative layer, and it would have the patient coming in to say, let me stay healthy instead of fix me out. Hey, I'm not sick enough for an insurance claim. Barry, you mentioned fee for service, and versus caring for a population. So let's talk about COVID. And under the fee for service system, all providers rely on volume. Hospitals, doctors, radiology centers have to do enough procedures for the fee in order to cover their costs. During COVID, had the fee-for-service system remained in place without special legislation, every health system in America would have gone bankrupt. So,
yes,
how did we?
Some
indeed.
did, yeah.
And how did we do under COVID? And were there any lessons to be learned that we could carry into normal practice?
Well, that's a loaded three-part question. So yeah, the finances were difficult on hospitals.
Don't be shy, because our audience is looking for unvarnished candor, and they can't get it anyplace else. So let's go ahead. They're tuning in to hear you.
Barry's always been very shy. We try to pull him out.
I could tell that. All right.
I majored in brashness.
Thanks for joining us on The Common Bridge. Subscribe to The Common Bridge on Substack.com or use their Substack app, where you can find more interviews, columns, videos, and nonpartisan discussions of the day. Just search for The Common Bridge. You can also find The Common Bridge on Mission Control Radio on your Radio Garden app.